Hello, good morning. Today I'm talking about supplements that may be useful in preventing viral infection. Yeah, there's a number of supplements that are relevant to uh, prevention when it comes to viral infection generally. The primary items are nutrients, and there are some botanical elements I'll reference as well. First nutrient is vitamin D. Vitamin D is, of course, a prohormone that our bodies can produce when exposed to sunlight. However, this time of year at this local latitude, that's not a possibility for us, so supplementing is really necessary for maintaining immune response, regulating immunity in general, controlling inflammation, etc. So vitamin D, generally my recommendations for maintenance are 2,000 to 4,000 units a day. That recommendation has changed over the course of the last year. I've actually increased my recommendation to 5,000 units a day for adults. And the reason for that is that the higher the blood volume of vitamin D, the faster your immune response tends to be, which is critical for short-circuiting any pathogens that might have made their way into the system. So for that reason, I'm recommending an aggressive potency, at least through the winter, because our vulnerability tends to be higher in the winter anyway. And I choose a seasonal strategy myself. I do half of the winter dose in the summer just so that I can maintain my levels. So from the perspective of COVID specifically, there's quite a lot of evidence at this point that vitamin D is in fact a major biomarker when it comes to outcomes post-infection. And it's been shown that if your levels are above 30 nanograms per milliliter, you will have a much better outcome should you actually become infected. So that's a very important aspect to keep in mind, that it doesn't prevent you from being infected necessarily, but it can certainly lead you to be more resilient and recover with fewer complications. So that is obviously a compelling case. The next nutrient I wanted to mention was zinc. Zinc is critical for development and function of immune cells. It's available as a supplement in many different forms and potencies. I take 15 milligrams a day, that's 15 milligrams daily as a maintenance. If you were to become infected virally, up to 75 milligrams daily could be useful in the short term. One thing I do want to point out about delivery of zinc, there are circumstances where a lozenge might actually be more beneficial, because there is a potential route the virus travels, spends some time actually in tissues in the throat, and if the zinc from a lozenge would come in contact with that tissue, it may actually interrupt the viral journey, so to speak, and actually prevent the virus from traveling further into the respiratory system. So that's one thing to consider when it comes to making a choice with regard to which form and delivery method of zinc you might choose. Related to zinc is quercetin, which is a bioflavonoid. It's found in many different edible plants, relatively low potencies, unfortunately. Quercetin as a supplement is most useful in this context because it acts as a transporter for zinc to help zinc get into your cells. And zinc naturally is transported by transporter proteins that your body produces. However, when you take zinc as an additional volume in the supplement, it can be useful to have another element to help to carry that zinc more effectively and deliver it more quickly to where it needs to be. and common potencies for quercetin are 500 to 1,000 milligrams daily, which is pretty easily achieved by 1 or 2 capsules a day. The next item I want to mention is vitamin C, which is, as we all know, immune related, does support immune function. In fact, there are specific immune cells that actually store small amounts of vitamin C that actually helps them to function effectively. So in addition to the immune effects, it is a powerful antioxidant, which becomes more relevant when we have lower respiratory conditions. Can act as a support to improve outcomes in that regard. So there's several botanical items I want to mention. Andrographis is an Ayurvedic herb which has antiviral properties and also anti-inflammatory properties. So I take a maintenance of that myself every day, just to get a little extra protection where it's needed. And it's something that I would choose over echinacea, for example. Andrographis is actually a very fast-acting immune stimulant and has particular effects against viruses with regard to viral replication. Another similar herb is elderberry, which is a traditional immune tonic, has been around for a very long time as well. And it's particularly effective against enveloped viruses, which I believe the COVID virus is in that category. It hasn't been established to be specific to COVID in its effects, but theoretically it may help to discourage viral replication once again. And the final thing I wanted to mention, because it's been brought up to me a number of times, melatonin, which is popularly used as a sleep support. It is a hormone that suppresses the nervous system and induces sleep. It has been suggested that it's useful in cases of COVID prevention. However, with that, that may be the case, but because melatonin has a long list of contraindications, I think it's important to understand before you use it that you don't have any underlying conditions that would be contraindicated in that circumstance. So that's a brief description of the most important things that I talk about on a regular basis with my customers, and there's a lot more that could be said about each of these. However, the basic message that I want to get across is that these things are relatively inexpensive. They're fairly ubiquitous in the natural supplement market, and they can be quite useful for general health support, regardless of whether we're in COVID times or not. And I recommend them regularly to my patients, have done for years. I'm sorry, my customers, excuse me. This is something that is not unique to COVID necessarily. I would encourage everyone to please consider investigating these supplements for future times, not just for this current time, because we're always faced with pathogens. They're always going to be in the environment. There's no way to avoid them entirely, and the best strategy is to set ourselves up so that we're more resilient to these potential pathogens, and just in an effort to not to be a good host to the opportunistic viruses that might want to make us their home. And with that, I do want to hand it over to the good doctor who's waiting to take his turn. And if you have any questions, of course, I'll be around afterwards to help answer those.
Thanks, Joel. That was fantastic. Thank you for that great overview. So I'm Dr. Ben Hagopian. I'm an integrative family physician. As Kim introduced me with Maine Integrative Family Care, I've been counseling and treating patients for COVID since this all started. And I'm going to talk about COVID testing. And at the end, we'll banter a little bit about treatment as well. So I've done tons of counseling on testing, who should be tested, when they should be tested, which test. So ultimately, you know, the big takeaway point with testing is no test is perfect. So who should be tested? This decision should come down to your patient, between the patient and your doctor or your healthcare provider. So there are plenty of testing sites right now where you can go as an individual and get tested, which I think is great, but there's not always a lot of context with that. So the questions I always ask my patients are, do you have symptoms of COVID? Do you have fatigue? Do you have fever, body aches, headaches, cough, shortness of breath, loss of taste and smell, things like that? Do you have a close contact? Now the CDC is defining a close contact as either a direct inoculation. You know, the most kind of the grossest thing we could think of for an inoculation would be somebody sneezing in your face. And that would be an extremely high risk COVID exposure. But things such as, you know, being in a meeting for, you know, a couple of hours across a room with somebody with COVID is also a potential exposure. The CDC defines close contact as being within 6 feet of a case for greater than about 15 minutes, kind of cumulatively. So if you're in a meeting and you're moving around a little bit, 5 minutes here, 5 minutes there, it can add up. But keeping all that in mind, being aware that no test for COVID is perfect. So it is always nice to talk it through with your healthcare provider as to whether you should be tested. Which test depends on a number of different factors. So if you have symptoms of COVID and you're pretty early in your symptom, in your clinical course of COVID, or suspected COVID, I should say, the rapid antigen testing is probably the best way to go. So the rapid testing checks for antigens, which are proteins on the surface of the COVID particle. And these are FDA approved for use within the first 4 to 5 days of symptoms. After that, it doesn't work so well. As a screening tool, it doesn't work so well. So if you don't have symptoms, it doesn't work so well either. The challenge with these rapid tests is that while they are pretty good early in the course of symptomatic illness of COVID, they still have a reasonably high false negative rate. So in a recent study, they looked at the Sophia device, which is considered to be one of the best. And about the number was exactly 20% of patients who had COVID and who had symptoms tested negative on their rapid testing machine, who eventually tested positive on a more accurate test. So that's something to be aware of. If you are asymptomatic and get tested with a rapid test, that number of 20% false negative jumps to about 50 to 60%. So those rapid tests are pretty good, but they are really only good within the first 5 days of illness in symptomatic patients. So those are the first questions I ask my patients about, would be your timing, your symptoms, your exposure, and what type of test is appropriate. So if the rapid test is positive, you almost certainly do have COVID. If it's negative and your suspicion is still high, or if you're outside of those 4 to 5 days, or if you don't have symptoms but you have a high risk exposure, the molecular testing is the way to go. So this is where I usually recommend the PCR testing. So the PCR can take very small amounts of virus, usually from your nose or nasal passages, sometimes in the throat, and it can amplify it millions or billions of times. And it's a far more sensitive way to pick up COVID particles. The ideal timing for this test is about 5 to 7 days after exposure. You could still have some false negatives, and again, false positives are pretty rare, but false negatives they do happen occasionally. So it's not the 20% number. I don't think we know the exact number there, but I kind of put it around the 5 to 10% number from what I've seen on trials. But again, I do, as a physician, if someone tells me, somebody with COVID sneezed in their face, they're testing negative and they have COVID symptoms, I'm still going to encourage that patient to isolate or quarantine at home per CDC guidelines, because I take all of these tests with a grain of salt. Situations in which I would not test somebody who may have a high risk exposure or symptoms would be if they've had symptoms for 7, 8, or 9 days. And that has to do with the fact that the isolation period after a COVID diagnosis is 10 days, if you're feeling pretty good after 10 days. So that's a situation in which I would say, listen, you're close to the 10 days. Let's just keep you at home for a couple more days, and we don't need to know if you have COVID. And the other situation would be a direct inoculum, which would be somebody with COVID directly sneezing in your face. That's an extremely high risk exposure. And so again, you certainly can test somebody, but that's where I would not put a lot of stock in that test result, because the risk of that exposure was so high. So next, I'm going to talk a little bit about where to get tested, because there's a lot of confusion. There's a lot of places to get tested, some better than others, some more expensive than others. So the first place I usually send my patients to is the Maine.gov website. So if you were to Google Maine COVID testing, the first non-advertised post is the Maine state site that has all the different testing sites for both PCR testing and rapid testing. Now, the state has sponsored testing sites locally in Portland and Westbrook, and in Portland and at the Jetport as well. And all of those PCR tests, to my understanding, are free. They also do rapid antigen tests as well, and those are free, except at the Jetport, I believe they're $25. They have really good turnaround times. The availability is very variable. So sometimes folks can get in. Earlier in the pandemic, it was a little trickier to get in. I had heard wait times of 1 to 2 weeks, which essentially makes testing almost useless. But I would really encourage patients to check out that website and see when they can make an appointment. And it's with a good test turnaround time and low cost, that's usually the best option. The next options would be to check with your primary care office. So my office offers COVID testing. Most of the other, I think all the other local primary care offices offer COVID testing. The question is, what would it cost? When can you get in? These are questions I can't answer here on this webinar, but those are questions you should ask if you call. There are a number of other places to get tested. So CVS and Walgreens and urgent care facilities, these national places, national chains do have testing. Usually the testing is free, and I believe Maine has provided a COVID testing waiver for patients if they want free testing. But a lot of them will charge an evaluation fee. Some will, some won't. Some will take your insurance, some won't. The turnaround times also vary. So I've seen results from some of these places as soon as 1 day or as long as 10 to 14 days. So, if you get tested and 10 days later you get a result, that's really not a useful test. There is right now, which is great. My understanding is that it's still pending in the legislature, in the state legislature, but there is a COVID patient bill of rights right now that's being tossed around to require insurance companies to cover screenings, testing, and vaccine administration to make it free for Mainers. So right now, I believe the testing is all pretty much covered, but in terms of the evaluation I was talking about a minute ago, that isn't always covered. So trying to remove cost barriers for Mainers, I think, is really important to get a handle on this virus. That's pretty much what I have for testing. So we covered, who should be tested, which test should you get, again, symptomatic, early symptomatic rapid test. If you don't fit in that, in that bucket nicely, the molecular PCR test. Some patients will get both of those tests as well. And then where to get tested, start with the Maine.gov website by just Googling Maine COVID testing and checking that out. I'm going to pass it along right now to Dr. Drew.
Hey, my name is Drew. I'm a pharmacist here at Coastal Pharmacy, and I just wanted to share a little perspective on, pharmacist perspective on treatment options as an outpatient, and also on the vaccine that's available, or vaccines, I should say. I'll get right into the treatment first, and then as far as vaccinations go, I'll just be totally upfront. I'm unabashed, and I'm a fan of vaccinations. I received mine personally, and I recommend it for anyone who can get their hands on it, and I'll cover more information about that as we progress. But as far as treatment options go, there are very few that have a whole lot of evidence behind them for outpatient use. The first one that I'll talk about is just because it's most recent on everyone's radar maybe. About 2 weeks ago, the National Institute of Health has updated their opinion on ivermectin use for treating COVID as either prophylaxis or active treatment for an active case. On the 14th, they changed their stance from "we don't believe it's going to be effective, we recommend against its use" to "it's something they can neither recommend nor recommend against using. It needs more evidence," and that's just that it needs more studies that are well controlled and are what you would call a blinded study, so that it's in direct comparison to patients who are receiving ivermectin therapy and placebo. So until there are more studies done, I follow the NIH's recommendation, and that's it's up to your prescriber, up to your relationship with your doctor if you want to pursue that. It has shown some effects outside of the body at killing the COVID virus and slowing its viral replication. Also has shown some anti-inflammatory properties as well. It's been around for a long time. It's been around since the 70s, and it's FDA approved for a different authorization. It's for anti-parasitic. So this is a new realm for ivermectin. As far as side effects of ivermectin go, it's very mild, really well tolerated from most of what I've read about, and the side effects that are experienced are generally gastrointestinal related. It's something that I don't want to sell it for sure, but it does have benefits in that it's inexpensive in comparison to a lot of these other treatments for COVID. And also it's readily available. As far as my knowledge, most pharmacies do carry it in a tablet strength of 3 milligrams. Even here at our pharmacy on the other side of that wall, we've got ivermectin that we can encapsulate for custom doses that aren't available with the tablets. So there are some area prescribers that have started prescribing it and have shown that, or had their patients not progress to a point where they need to be hospitalized, which is where the hope is for that drug. And any questions on that, I'd be happy to answer at the end of the presentation. Next up, prior to this, the biggest development was in November when the FDA issued these emergency use authorizations for monoclonal antibodies, or biologics, the way to refer to them as. And there are currently 2 treatment options that are biologics that are approved under this emergency use authorization for non-hospitalized patients who are at high risk for becoming hospitalized or having adverse effects of this COVID vaccine or COVID virus. And to be considered high risk, we're talking about patients who are 65 and older, patients who have compromised immune systems, diabetes, a high BMI of greater than 35, which means overweight, or if you're over the age of 55 and just have hypertension or other cardiovascular diseases, or lung disease like COPD, or really anything that's putting your body at high risk. These can be considered for. They've got real tongue twister names. Bamlanivimab is one option. Another is the casirivimab plus imdevimab. and they are given by intravenous infusion. So these aren't something you can go to your Walmart, Walgreens, and just pick up with a prescription from your doctor. They are something you'd have administered over the course of an hour intravenously, and it is prescription for sure, but it may be a little bit more complicated to get your hands on these. Price could certainly come into play. I have actually no experience in ordering these to know what they are going to cost, but if it's something you're interested in, if you fit the bill for being a high-risk patient, I suggest mentioning it to your prescriber. Just have them talk through the options that they've discussed with their patients or have had some first-hand knowledge with. As far as how they work, these biologics, they are basically a man-made copy of antibody that is given through an infusion, and your body recognizes this. The antibody should help your body get a chance to build its own immune response, and the evidence out there, it's under emergency use authorization. It's not FDA approved yet. It needs more studies before it'll be approved and more evidence. So right now, even looking at side effect information from this, it's still under development. Still more information needed to have a really accurate side effect profile. Monoclonal antibodies in general actually increase your body's risk for opportunistic infections, and that's something that is seen pretty much across the board with other monoclonal antibodies that have been on the market for longer. So I'm interested to see what comes out as more of these are administered, but so far safety is the key concern for the FDA, and it does appear to be safe and worth considering with your prescriber anyway. Something we touched on a year ago, if anyone had tuned into the webinar we had then, was the hydroxychloroquine with or without azithromycin. And I pretty much follow the stance of the NIH on this as well, in that they don't recommend its use for outpatients, and only in the cases of clinical trials or special circumstances, but generally just kind of gone downhill in popularity since its initial hype about a year ago. Mention it to your doctor still. I'll keep saying that. I don't want to push anyone into any direction which way to go. It's something that's a very important decision to make with your prescriber. And then another option, I'll preface this by saying I'm not fully confident in its use, in that I don't know exactly the mechanism and dosing that has been proven, just because there aren't full studies for me to review on it. But some area prescribers, and there is some literature out there, so you might have seen it, is a nebulizer treatment with hydrogen peroxide with or without iodine or Lugol solution. And the theory there is it's an oxidizer, and if you nebulize it and are able to inhale it deep into your lungs, and it penetrates deep into those alveolar cavities, it can kill the COVID virus. And it's relatively safe when used as a food grade hydrogen peroxide, not just what you grab at Walmart, the bottom shelf. It does have some evidence out there just because it can kill viruses when used on surfaces, and it's mild enough to be safe for human use, but I haven't seen anything that's really solid, like this is a definite yes, we should get right on it as far as clinical evidence. So if it's something you're considering, mention it to your prescriber, and perhaps they have some personal experience or have tried this with other patients and maybe worth pursuing. So that's about it right now for outpatient options. As an inpatient, there are several others, but I won't get into those, because at that point, if you have developed COVID infection to the point where you need hospitalization, someone else is going to be taking over your clinical decisions, and that'll be a whole different ballpark. But I'll try and rush through here with the vaccinations. Number one thing with vaccines, there's two options out there right now. Moderna makes one and Pfizer makes the other. Just get whichever one is available at the time. Moderna is a little bit different in that it is given every 4 weeks, so you get one initial dose, then return for a second dose 4 weeks later. Pfizer's is a 3-week gap. It's important to get the second dose unless you have a really significant reaction to the first. You don't want to get it, but immunity doesn't really take effect until 1 or 2 weeks after your second dose. So keeping to that schedule is helpful. Right now, it's indicated for anyone 16 and older with the Pfizer vaccine and 18 and older with the Mrna vaccine. And basically, even if you've had COVID infection or have had one in the past, it's unknown whether that natural immunity you've acquired is long-lasting. It's actually still unknown whether the vaccination immunity is long-lasting. It'll be something that we learn more about as it goes on. But if you have had the virus, still a good idea to get vaccinated. And the only real contraindications, I talked about the biologic therapies. If you've had one of those infusions in the past 90 days, you should not get the vaccine. It will be less effective. If you've had another vaccine different than the COVID vaccines, it's best to separate it by 14 days, both sides. Side effects from it, I can tell you, it gives you a sore arm. The first one didn't really do anything else. The second vaccination, likely to give you some side effects like fever, chills, headache, basically feeling pretty run down, and that's totally normal. These vaccines are very similar to flu vaccines in that sense, side effect profile-wise. The difference between them is that these are what's known as mRNA vaccines, and instead of injecting particles, tiny microscopic particles, proteins that have these virus proteins into the body, and then your body recognizes them, builds an immune response. In this case, with mRNA vaccines, you're actually injecting mRNA, which instructs your cells to build its own proteins. So your body then builds these proteins, displays them on cells, and your immune system recognizes these proteins, which are just like the ones that COVID has, and is able to build an immune response. The benefit and the reason for this is that it can be developed very quickly in the lab and wide or giant scale. Like we've already, as a country, ordered 600 million doses of this, which is impressive. Past vaccines like flu vaccines, they have to be grown in egg, and they're cell cultures, so it takes a lot longer to produce them. I know I've heard a lot of people who are afraid about these mRNA vaccines just because it's a new kind, and is it messing with my genes? Am I going to develop all these other different potential gene mutations? And the answer is no. It's not possible. These mRNA vaccines cannot enter inside the cell nucleus, which is where your DNA is stored. So it's actually harmless. It's injected, instructs your cells to make proteins, and then your body breaks it down, and it's done its job. So I do advise, if you have further questions on it, I'm getting most of this information right from the CDC website and the Maine CDC vaccination website. They are very up to date with their recommendations. They have a great Q&A section, so you can review specific questions about whether it's a good idea for you personally to receive the vaccine. I know that close to like 10% of Maine has been vaccinated already. About 115,000 doses have been given as of yesterday. So we're on track. It's not really known at what percentage we reach herd immunity, but estimates anywhere from like 70 to 90% of the population hopefully would get vaccinated to give us that herd immunity. So I know I threw a lot of information out at you. I've been rambling a lot, but if you guys have follow-up questions, I'd love to answer them, and we'll all be here.
Drew, I do have a couple of questions right away from Dr. Krasner. Is there any info on effects of the vaccine on fertility?
I haven't heard of anything about the vaccine effect on fertility. I'd have to look more into that. I know that right now, as far as pregnancy goes, it hasn't had enough evidence. There haven't been enough studies to show its full safety profile in pregnancy. The CDC is still recommending to discuss it with your provider, your doctor, and make that decision based on personal list of pros and cons. But it's theorized as being safe. And I can't off the top of my head think of a reason not to use it in a patient undergoing fertility treatments, but I can get back to you on that.
All right, great. And then also she was asking, what about using Tylenol or other meds to mitigate the side effects before or after you get the vaccine?
That's smart. I did that myself. I am a fan of Tylenol, and that will help mitigate the flu-like symptoms that you may be getting, the fever, or chills, or soreness. It's not going to affect the vaccine itself. It'll still be fully effective, and it'll give you more comfort. And if you're looking for other ways to treat that sore arm, for instance, exercise it. It's counterintuitive. People think they have to kind of wing it and hold their arm tight, otherwise it hurts when they move it. But if you're able to do jumping jacks, arm exercises, just arm raises throughout the day, the more blood flow you get through there, the more muscle use, more beneficial, the faster you'll recover.
Okay.
Can I chime in here just for a second?
Yeah.
So I can't speak about the vaccine. I don't think we have enough data on the vaccine I'm going to echo what Drew said here about the vaccine fertility. But I have seen, I'm on a couple nationalized Facebook groups, and a couple of doctors have anecdotally said that they have a couple of female patients that have had pregnancy loss due to COVID, due to being infected with COVID. So that, it is going to increase. I think it would make sense that it would increase risk during pregnancy.
Okay. And I think that this probably, I'm glad you chimed in because you're probably going to be the one to address this issue. Should someone who is being treated for Lyme get the vaccine? Dr. Hagopian, do you have that?
Yeah. So I assume what that means is, that question means is they're being treated for either acute or chronic Lyme disease. I think ultimately, if you're concerned about immune system function and dysregulation, getting the vaccine is in your best interest. I do think that's the case. A quick Google search of ingredients in the Mrna vaccine or the Pfizer vaccine can tell you what's in there. So obviously, if you have a sensitivity, I wouldn't really even call it a sensitivity, but I call it a true allergy to any of the ingredients in the vaccines, that would be of concern. But in terms of Lyme disease treatment, I'm not aware of any reason to not get the vaccine. That's unrelated to the vaccine ingredients.
Regarding that question on the Lyme treatment, it would depend on what medication that's been prescribed or what treatment they're undergoing. Really, the only risk I can think of, I agree entirely with what Dr. Hagopian had said, but if you're undergoing a treatment that does affect your immune system to reduce your immune response, then that would be the only thing that I could think of that would interfere. Most Lyme treatments that I know of offhand aren't going to be an issue, but if you want to give us a call or your primary care physician a call to just mention what it is you're being treated with, and then that'd be an easier way to answer the question.
Okay. Thanks, Drew. So Dr. Hagopian, I'm going to go to you on this because I think that you have some information. The vaccine rollout in Maine has a lot of people, especially those in group 1B, frustrated. Do you have any advice on how to register for the vaccine and what people should do in the meantime while they wait? Also, what your thoughts are on the rollout and what can be done to make it less frustrating, other than more vaccine, obviously.
I'll say this tongue in cheek, but welcome to the club of being frustrated with the COVID vaccine roll. This is challenging for everybody. We were supposed to have a stockpile of vaccine that didn't exist, and I think President Biden has made it his priority, his number one priority. So hopefully things will be rolling out soon. So my understanding is if you're a patient at a large practice, at either a Martin's Point or an Intermed, they have a vaccine. They have vaccines for their patients. I don't know what their supply is. If you are a patient of a Maine Health or a Northern Light practice, or if you have a primary care doctor outside of those systems, or don't have a primary care doctor at all, the Northern Light and Maine Health sites are open to the public. I did check the Northern Light site yesterday, and it said that they were out of vaccine and to check back soon. The Maine Health site, and I can give the phone number out because this is public information, but the number is 877-780-7545. My understanding is that if you are eligible in phase 1B, or if you're ineligible but want a vaccine at some point in the future, you can call that number 877-780-7545, register for an appointment, and the system will call you when you're eligible. The system, I'm sure, is not perfect. I think they're doing it mostly based on age. You can certainly talk to your healthcare practitioner if you're higher risk. So, you know, if you're young and healthy and in your 20s or 30s, it's probably going to be a number of months before you can get a vaccine. But if you're, you know, obviously if you're over 70, you should be getting vaccinated very soon. Or if you're a very high risk patient on immunosuppressive medication or have lots of medical problems, definitely talk to your healthcare practitioner, and they can see if they can get you in phase 1B or 1C. You know, tough question on the rollout. I think they're doing the best they can with what supplies we have. I think our supply is limited. Initially, the thought was the distribution channels were not up and running, and then we found out the stockpile didn't exist. So it's really tough. I think you know, Dr. Shah and Governor Mills are, you know, they're doing the best they can. We are seeing, you know, I did just see an article yesterday about a drive-through vaccine clinic in Brunswick. So we're starting to see resourcefulness of Maine, and I just think we all need to be patient. I'm telling myself to be patient. I'm telling my patients to be patient. This is a tough time. It's probably going to be, you know, I'm telling my patients who are eligible or will soon be, it's probably going to be a few weeks to a few months, and that's the best I can suggest right now.
All right. So I'm going to ask this of Drew. If you don't get the second dose of your vaccination, what is the effect of that? So is it just that it's reduced in efficacy? Is it totally wasted?
Yeah, it's something that is kind of an unknown. It depends on your immune system and how your body responds to that dose that you did receive. The studies that were done were over a huge patient population. And what they were finding is, in order to have a sustained response for the majority of people, it required that second dose. So it's a variable. You need, I would say, for most people, you will need that second dose to have the immunity from COVID, but it's possible you might have some immune response if you just get one shot. I would advise against it, but you're going to have some antibodies available and some means to fight off the COVID virus, just probably not enough to mount a full attack, and you probably are still going to get sick, is my guess.
Okay, thanks, Drew. And Dr. Hagopian, I'm going to ask this one of you. A lot of us are wanting to get back to dining out because we're not in summer anymore, so we can't really dine outside as much. But what are your thoughts on the enclosed outdoor bubbles, or some have little greenhouses that are popping up around restaurants? Do you think it's safe to use those as long as there's enough time in between? Do they have to air them out after each group? What are your thoughts?
That's a great question. That's a tough one. I would say, you know, every restaurant that's doing that, I think, is taking this seriously. So I think that's a check in the right box for that restaurant. I think if you're going with folks in your pod, you know, and I'm talking about, you know, within your family, or the let's say 3 to 8 people that you're seeing regularly, you know, I think if these restaurants are putting out those enclosed spaces, they're taking it seriously. They're closing it down. They're wiping it down in between. A lot of them are outside. So I think all of those combined, if you're being safe in your personal life, these restaurants, you know, again, I'm using the outdoor enclosed greenhouses as a surrogate for their safety, and I think that's a positive way to both serve the community and to be safe. I think overall the risk is probably substantially lower than indoor. It is substantially lower than indoor dining. Is the risk zero? Probably not, but I think it's definitely a way to help us get through this pandemic and give us some sense of normalcy. So I will tell you, in full disclosure, we've done that one time with a restaurant that we trust, and we know their protocols and their cleaning protocols, and we felt very safe. The staff was wearing masks. We were, 6 feet, well more than 6 feet away from everybody else. So I think, do your own research, talk to the restaurant owners and see how you feel about going. But I do think ultimately it's going to come down to, are you masking? Are you distancing? Are you washing your hands and not touching your face? And I think that's going to be more effective in the long term than going out to eat, once or twice every month or two. So tough answer to a tough question.